The facial nerve, also known as cranial nerve 7, is responsible for controlling muscles of facial expression, conveying taste sensations from the anterior two-thirds of the tongue, and supplying parasympathetic fibers to the lacrimal, submandibular, and sublingual glands. In its normal course, the facial nerve follows 5 distinct segments. First, the intracranial segment originates from the brainstem at the pontomedullary junction. Next, the intracondylicular segment enters the internal acoustic meatus in the petrous part of the temporal bone, traveling alongside the vestibulocochlear nerve. Third is the labyrinthine segment, where the nerve takes a sharp turn at the geniculate ganglion. Then, in the tympanic segment, the facial nerve runs through the middle ear just above the oval window. Finally, the mastoid segment exits the skull via the stylomastoid foramen and branches to innervate facial muscles and glands. This normal pathway is essential for understanding deviations or anomalies in its course. Anomalies in the course of the facial nerve can occur at any point along its pathway. These anomalies can be congenital or acquired, leading to clinical complications. Congenital anomalies arise due to irregularities during embryogenesis. Some examples include the aberrant origin of the facial nerve duplication, or an anomalous pathway in the temporal bone. For instance, the nerve may run in close proximity to the ossicles in the middle ear, increasing the risk of injury during surgery. Acquired anomalies are often due to trauma, infection, or tumors. Facial nerve compression by tumors, such as schwannomas, can cause displacement or compression, resulting in altered nerve function. Trauma-induced anomalies can occur from skull fractures, leading to facial nerve palsy. Lastly, post-surgical anomalies can arise after surgeries like mastoidectomy or parotidectomy. Anomalous pathways of the facial nerve can lead to various clinical challenges. One of the most significant is facial nerve palsy, where patients may experience muscle weakness, inability to close their eyes, or loss of taste sensation. Anomalies also pose risks during surgeries like mastoidectomy or parotidectomy, where surgeons must be cautious of abnormal nerve positioning. Diagnostic tools like high-resolution CT or MRI are crucial for identifying these deviations, especially before surgery. Electrophysiological studies, such as electromyography and nerve conduction tests, can assess nerve function in cases of suspected injury. Treatment may involve conservative measures like corticosteroids or physiotherapy for mild cases. For more severe conditions, such as tumors compressing the facial nerve or post-trauma cases, surgical intervention may be necessary to repair or decompress the nerve.